Welcome to Mandatory Hip Arthroscopy. This is a presentation on hip arthroscopy making it work by Mr. Max Feely, consultant orthopaedic surgeon at the Royal Bolton NHS Foundation Trust and the BMI hospitals in the Alexandra in Manchester and the Beaumont in Bolton. Hip pain can be difficult to work out when patients first present, particularly when they've had long-standing problems. The most common area of pain is the groin, but they can occasionally get symptoms around the buttock area, the sacroiliac joint, and also the lateral hip region. And occasionally it can be radiating down the leg to the anterior aspect of the knee. So when you see these patients for the first time, it's important to try and work out, are there symptoms coming from inside the joint, i.e. intra-articular, or from outside due to other pathology, which is extra-articular. So you need to work out what the underlying pathology is. There are multiple intra-articular causes, but in younger patients who present with groin pain, the most common in my practice is due to femoroacetabular impingement. In other words, impingement between the head of the femur and the acetabulum. Following on from that, they can either have a cartilage tear, they can have joint surface damage, or if the symptoms have been present for long enough, they can have established osteoarthritis. Less commonly, they can have loose bodies, abnormalities with the blood supply to the femoral head, which is avascular necrosis. They may have widespread inflammatory conditions such as PVNS, or ligamentum teres tears, or stress fractures, which is less common. Impingement is where the neck or head of the femur bashes up against the rim of the acetabulum. So here's a plain X-ray showing a nice concave surface underneath the femoral head and a bossed superior surface. As a consequence of this, they can develop labral tears, they can get a painful inflamed psoas tendon which normally runs over the front of the hip and can start clicking. They can start to get adductor tendinitis, which is pain in the inner aspect of the groin, or more widespread pain on the outer aspect of the hip, which is commonly called trochanteric bursitis. This was an interesting paper published by Holmick et al. In the British Journal of Sports Medicine back in 2007, and they looked at over 200 high-level athletes with long-standing groin pain. And what was interesting was that over 2/3 had adductor-related pain, and these tended to be footballers. A quarter had painful iliopsoas tendons, and these were the runners. A third, though, had 2 different entities, and 8% had 3. And so often when you see these patients in clinic, particularly when they've had their symptoms for a long time, they can have generalized pain all around the hip girdle. Here's a line drawing explaining femoroacetabular impingement a little easier. So here's a normal hip at the top, so nice concavity coming down from the head down to the neck, and as the hip flexes up, the acetabular rim with its soft labrum sits nicely into that concavity. Some patients, usually women, have an overhanging cup, and so this is a pincer deformity, and as the hip comes up, it bashes against the rim and causes almost a contre coup injury on the other side of the femoral head. Other patients, often men, have what's called a cam deformity, so they have a swelling on the anterolateral aspect of the head, and as they bend up, they again bash against the rim of the acetabulum, causing similar damage. Here's animation explaining a cam deformity. So here's the abnormal swelling, and the cause of this is unclear, but probably occurs around puberty. As the patient repeatedly bends up, you start to get micro damage to that soft tissue rim, the labrum, eventually causing a tear at the junction with the hard bony acetabulum, which we'll see in a second, usually in that region there. And with time, you'll start to get joint surface damage, with the joint surface cartilage peeling back. And so here, when the head's been removed, we can see that this is often the region of the articular cartilage damage. Looking at a pincer deformity, which is somewhat different, so this is due to an overhanging rim, but a normally shaped femoral head and neck. As that patient repeatedly flexes up, again we start to see damage to the soft tissue labrum. As that is peeled out of the way or torn, we'll start to see damage to the joint surface cartilage but we may also see damage at the back of the acetabulum. And again, once the femoral head is removed, we'll get a better view of that. Here we are now. This area here. So the main area of joint surface damage is in a way similar to the cam deformity, but they may also get this associated damage in the back. So when seeing these patients, you need to be aware. Some of them are very difficult to pin down clinically, but the vast majority will have had symptoms for a number of years, will have been to see a number of medical practitioners already with no diagnosis. When they're screened by the general practitioner, I've had x-rays, they're often reported as normal, so they're simply sent off to the physiotherapist. If they do have a good rehab program, some of their symptoms will get better while they're doing their rehab, but as soon as they stop, those symptoms will recur, mainly because the underlying bony abnormality has not been addressed. So how do you pick a winner? How do you decide who will do well from surgery, what type of surgery you need to do, and perhaps more importantly, who won't do well from surgery? So it's a combination of examination, suitable investigations, appropriate surgery, and appropriate rehabilitation. And it's hard to overemphasize the importance of the rehabilitation. So the vast majority of these patients are sporty, athletic patients. We've had a small number of obese patients with groin symptoms. Interestingly, at least 3 out of the group, their symptoms have completely resolved simply by losing weight. And when we did scope a couple of patients with BMIs over 30, they only got a partial recovery, and I'm sure this is due to their body mass. So, on examination, you look for areas of tenderness, so the groin crease, particularly looking for evidence of hernias. The anterior superior iliac spine, where sartorius comes in, the adductors, the trochanteric area, and the sacroiliac joint. And certainly, if patients have had symptoms for a number of years, they'll often be painful all over these areas. They'll have a positive impingement test, i.e. pain in the deep groin when you deeply flex the hip with internal rotation and adduction. They may well have an inflamed psoas tendon, so when you do the McCarthy or the psoas irritation test, you'll get a snapping on the front of the groin. And if there's any doubt as to the source of their underlying pain, a hip injection using steroid and long-acting local anesthetic can be very useful. My radiology has changed over the years, but certainly a plain x-ray is very useful, and that allows you to look at the acetabulum. I still occasionally use an MR scan, I'll talk about that in a second, but certainly since the last 12 months, the use of CTs with 3D reconstructions is extremely useful. So here's a plain x-ray of the hips in an immature patient. We can see the right hip and left hip, good joint space preservation. But if you look very carefully at the acetabulum, you can see that's the back wall of the acetabulum there, coming up here, and that's the front wall coming there, and they both meet and cross over at that point there. And this is indicative of a pincer impingement. They should actually meet right at the very top of the acetabulum. And here's a line drawing, simply emphasizing the same thing. So this was the anterior wall, and this is actually the posterior wall. So it's incorrectly labeled. And again, here's an x-ray from the internet with the 2 lines drawn, which isn't quite as clear. So here's another patient, again looking at the left hip, posterior wall coming up, and if you follow it with the cursor, it comes up there, and an anterior wall coming up, and then they cross over there, and again, that's the sign of a pincer impingement. Sometimes side views are useful, although it's very important to remember that you're only getting one slice on the plain radiograph, and it's very easy to underdiagnose both the presence of a cam deformity and the extent of it by relying on x-rays. Here's evidence of a cam deformity, and this was done using the lateral view of an MR scan. That's why the arrow is pointing to the labrum. But what you see is a perfect sphere drawn in, and then the cam deformity forming. So we see that it's at the junction of the head coming into the neck. X-rays are also useful looking for very abnormal hips. So this is a patient with hip dysplasia where the acetabulum doesn't fully cover the entire head. And this will have been present since birth, but probably not severe enough to show up during early childhood. But the problem with these patients is that the whole weight-bearing portion of the hip is over this small area. And no matter what you do arthroscopically, they actually need a more fundamental treatment, and we'll talk about that later on. So here's an MR arthrogram. It's useful looking for labral tears. It's useful for looking at other pathology around the greater hip joint. It will also show up ligamentous teres tears, synovitis within the hip, or avascular necrosis. But what we found when we audited our results was that it was oversensitive looking for labral tears, i.e. it tended to overdiagnose them, and was very poor at looking at articular cartilage damage in the acetabulum. So we only use it now for cases that are not clear cut, where the whole clinical picture is a little confused. So we moved towards using CTs, particularly with 3D reconstructions, and I think you need the reconstructions for it to be of any use. So looking at a pure cam deformity, here's a man in his 20s, and this is the posterior view of the hip. So nice ball, concave neck, concave inferior neck. But when you look at the side view, you can see that he has quite a large cam deformity, which is triangular in shape. When you look at the front view, again, we see that large deformity there. And so knowing that he had this deformity, we were able to preoperatively plan carefully and resect that whole region. Some patients will have a pure pincer, and this was a young female in her 30s. Nicely shaped femoral head coming into the femoral neck. No evidence of a cam deformity there, but she did have an overhanging acetabulum here. So it's quite a subtle finding, but it was enough to cause her symptoms, and so that was resected. That's the side view. And sometimes we'll see a mixed picture, which is actually quite common. And so this was a young man with an overhanging acetabulum, as well as a mild cam deformity. So not as pronounced as the first patient, but because he had an abnormality on both sides of the hip joint, it became very symptomatic. And we'll also sometimes see patients with very abnormal rims. So this was a young man in his late teens with very painful hips bilaterally. X-rays looked a little abnormal, but not obvious. But once you saw his CT scans, it was clear that his soft cartilage rim had actually ossified and turned into bone, and that's why he was so symptomatic. He didn't have a gross cam deformity on his femoral head. Here's the side view again. This is an older patient in his 50s, and when you look at the x-rays carefully, you can see that his true acetabulum ended there, and this whole region here is ossified bone. And previously this would have been reported by the radiologist showing an osteophyte. What it actually was a grossly ossified labrum. So this whole region here is all abnormal, and he had a mild cam deformity here on the femoral neck. And that's just showing the lateral side, and this all had to be resected. And this is quite an unusual patient. He had gross ossification of his labrum, although still well-preserved joint surfaces, and he was only in his 40s. And this was the CT scan showing it bilaterally, and that's often the case. You often do have the deformities on both sides, but because one leg tends to be the dominant leg, and that tends to be the one that's the most painful, and again showing the abnormality all around here, and this is all grossly abnormal. So what do I do? Well, you need to tailor the surgery to the actual abnormality of the patient, and that's where the CTs come in. Patients with a mild pincer, where you have a line joining sign rather than a gross crossover, you treat any labral damage, clear the capsule off the rim, and then resect the acetabular rim, leaving the labrum intact. And that makes a big difference to their postoperative rehabilitation. In patients with severe pincers, who have a full-blown crossover sign, you're actually better detaching the labrum using an arthroscopic knife. Then you're free to resect the rim, and then you can reattach the labrum using arthroscopic anchors. Patients with a cam deformity, it's very important to work out where that deformity is, as there's a number of different approaches to the hip joint. And if it stretches right over onto the lateral edge of the hip, you then have to come in over the top from the central compartment, start shaving there, and then work your way forward, making sure that it's fully resected. If it's a combination of the two, you can treat any labral or chondral abnormality, do a sublabral rim recession, and then do a femoral head reshaping. And it's by attacking it on both sides that you make the best effect. Severe ossified labrums are very difficult technically. They're hard to do. They often require long traction times. It's essential to do accurate preoperative planning using your CTs. You may need to do blind entry with an X-ray, i.e. having to punch your way through the labrum, and then slowly starting to improve the access using the burrs, and you basically carry on and resect down to a normal rim. So that's where this patient's normal acetabulum was. This was all abnormal. And when you look at the post-operative x-rays, we're back to the normal acetabular rim, and all the abnormal bone was removed. Rehabilitation is essential, and we have a well-established rehabilitation program which basically brings the patients through the early post-operative period using a combination of hydrotherapy and gentle range of movement exercises, and then they're gradually brought through the whole program where all the muscles are strengthened back to normal level of sporting activity. In cases which are unclear-cut, we sometimes use this rehabilitation protocol preoperatively, as it's often very useful to get rid of the surrounding hip girdle pain, but patients will be left with the underlying groin pain because the bony abnormality has not been addressed. A copy of that protocol is on the website. So where are we up to? Since we started 3 years ago, we've now done 136 hip arthroscopies, divided between the Royal Bolton NHS Hospital and the 2 private ones. We've audited these patients prospectively from the beginning. They've all had a comprehensive rehab protocol and are now beyond 2 years follow-up, and they've all had prospective functional scoring. Looking at the McCarthy function score, which is a soft tissue hip score designed by Joe McCarthy, they had a median increase from preoperative score of 56 up to 76 at 6 months, and this carried on up to 24 months, up to 88. Patients over 50 years are a little different. They tend to have a slightly worse score initially. They didn't do so well at 6 months, but at 12 months were starting to come up to the same level. So that showed that the older patient tended to take a little bit longer to get the full benefit of the arthroscopy. And so it's important not to go rushing in to something like a hip replacement. You need to give the patient time to recover from the surgery stop. Even though hip arthroscopy involves only small incisions, a lot of work is done inside the joint, and it does take time for the hip to settle down afterwards. There are patients who won't do well from it. Certainly if you've got a significantly abnormal acetabulum with a dysplastic hip, they tend not to do well. What they really need is the acetabulum itself moved, usually by way of a periacetabular osteotomy or a Bernese osteotomy. If they've got widespread inflammatory arthritis, they tend not to do well. If they've got gross damage already on arthroscopy, i.e. the condition's been long-standing, they will probably get a temporary improvement, but those symptoms will recur. And certainly we now see patients who've had arthroscopies elsewhere where the full impingement lesion hasn't been addressed properly, and they will carry on getting pain until they have a proper resection. The future, people are already carrying out labral reconstructions. Certainly there's been some ligamentum teres reconstruction done both in the US and the UK. We're now starting, we're already carrying out microfracture in both the femoral head and the acetabulum, but we're now starting to look at retrograde osteochondral grafting to both the head and the acetabulum. The use of grafting in patients with avascular necrosis, and we've done some work looking at computer-navigated hip arthroscopy, which is very interesting, and also uses CT reconstructions. I'd say thank you for listening to this talk, and if you have any further questions, we can be contacted on info@manchesterhiparthroscopy.com.